Please be seated. We'll start our proceedings. Good morning. A warm welcome from ISCCM Hyderabad. And it's my pleasure and privilege to welcome you all for the CRITIC 2024. And first of all, I would like to thank our scientific committee led by Dr. Srinivas Samavedam sir, Dr. Venkatraman Kola for the well-drafted scientific schedule. And I am sure that you will all enjoy the academic feast. And I will pass on my mic to Dr. Deepak, who will share his few thoughts.
Good morning, everyone. Thank you, sir. So it has been our pleasure to actually invite you in the morning to look at you. And we're also actually eager to listen to all the stalwarts in the critical care. So Critic, as you know, it has been our signature event of ISCCM Hyderabad. And every year we kept on innovating. We added workshops, we had abstract events, we had prizes for the students, best outgoing students in various exams. So this year also, as our tradition 2024, we come with a very exciting academic feast today and tomorrow. So we'll be having poster presentations, paper presentations. We are eager to listen to our speakers as well. Again, I would like to thank the scientific team, abstract team, workshops team. Many of the workshops were also very well coordinated by the workshops chairperson, as well as the directors and the coordinators. Without much delay, I would like to hand over the mic to Dr. Pankaj. So Dr. Pankaj is our executive committee member who will be coordinating the first session. Thank you, Dr. Pankaj.
Thank you, Dr. Deepak. And a warm welcome and good morning to everybody for Critic 2024. We'll be starting out the first session. To chair this first session would be Dr. Surender Pasupuleti. Sir is an emeritus professor of anesthesiology at Mallareddy Medical College for Women, Hyderabad. Sir. With permission of the chairperson, I would like to introduce our first speaker. He, sir, doesn't need any introduction. He's Dr. Srinivas Samavedam, sir. He is currently the chief intensivist at Sindhu Hospitals, and we know him better as the president-elect of the Indian Society of Critical Care Medicine. Sir.
Thank you. Good morning, and it's always a pleasure and honor to be here at Critic 2024, the signature event of the Indian Society of Critical Care Medicine. Um, it's always difficult to be an opening bat when the whole conference is beginning to unfold. What you do or what you don't do probably determines how good you performed in the first 20 overs or 30 overs when the ball is new and it's swinging at 20 degrees temperature. So let's first look at, I've only got 15 minutes to talk about this complex scenario of markers of resuscitation. Where do we stand? So I'm not going to talk about what is the relevance of CVP, what is the relevance of base excess. I'm not going to go in a didactic way. Probably put back into perspective some of the well-known parameters which we have used, discarded, and probably are re-emerging back into the fold of critical care medicine. We start resuscitating patients in the emergency room, in the ICUs, or in the operating rooms on the basis of vital signs: heart rate, blood pressure, respiratory rate, maybe shock index, maybe the urine output, the sensorium, all surrogate markers of hypoperfusion. And when we start that, we look at certain targets. You look at the targets in the macro circulation, and then you look at targets at the micro circulation level. Multiple targets at the macro circulation level have been identified, and we follow them very well, whether it is the partial pressure of oxygen, the saturation, or at the cardiac output, the preload markers, or the oxygen carrying capacity. These are the ones which will determine the hemodynamic and global oxygen delivery. The interventions which we therefore apply using these parameters, we try to monitor and then say, is my intervention going in the right direction? And that's where your markers of resuscitation come in. And we have a lot of them called lactate, base excess, extraction ratios, venous saturations, acid base. And of course, now in the field of trauma resuscitation, ROTEM has come as a big marker of non-coagulopathic resuscitation. So when you look at the macro circulation and micro circulation, you know that you have the preload markers, you have the contractility markers. Similarly, at the biomarker level, we have the lactic acid, we have the SbO2, we have procalcitonin, we have the pH and the endothelial biomarkers. The whole concept of resuscitation and safe resuscitation is coming down to the glycocalyx level. So you have markers of glycocalyx integrity called angiopeptin 2 and hyaluron, which will tell us whether your glycocalyx has suffered because of the or injudicious use of certain types of fluids. Can you look at the microcirculation? Experimentally, yes. Some advanced centers are looking at functional capillary density, the perfused vessel density, microvascular flow index, but still they have not become part of the standard tools which were used in the intensive care unit. End of the day, we are just left with this hemodynamic optimization pyramid. If you look at all your markers like intravascular volume, venous return, the LV diastolic time, the status of the aortic valve, preload, afterload, end of the day, you are looking at two markers, that is organ perfusion and tissue metabolism. Am I sending enough blood to the organ, and is the organ actually extracting enough of the nutrition from the blood to survive and carry on with its metabolic activities? So that is what determines your supply and demand balance. And at this point of time, given all our armamentarium we have at our disposal and the current knowledge of medicine, blood pressure seems to be the only determinant which looks at both organ perfusion and tissue metabolism. So you need to look at this hemodynamic triangle. So you have the blood pressure, which we said is the apex of that pyramid, which is the determinant of all the outcomes. And you have the two important determinants, that is cardiac output and vascular resistance. You find situations where the vascular resistance is low, and you find situations where the vascular resistance is high. You may find situations where the cardiac output is low, and you may find situations where the cardiac output is less. So in certain kinds of situations where you have a decrease in vascular resistance, like a neurogenic shock, for example, you have vasodilatation, your vascular resistance falls, but as long as the cardiac output remains stable, there is no organ perfusion. That is the gist of looking at a pure vasodilatory state not producing organ hypoperfusion. So it may produce hypotension in the pure definition of the word, but it does not translate into organ perfusion. On the other hand, if you look at other triangles which look at hemodynamic situation, you have a situation where your vascular resistance remains normal, like a hypovolemic shock, but because of the low intravascular volume, if your cardiac output falls, then you are more likely to have a decrease in organ perfusion. Similarly, if you have a situation where your blood pressure is low and your cardiac output decreases even further, like in myocardial infarction, you have a further decrease in organ perfusion. This is magnified when a vascular resistance drop is added to the decrease in cardiac output. So end of the day, we are left with the situation where we need to determine the two variables which are controlling your cardiac output, that is your stroke volume and your heart rate. You don't usually try to manipulate your heart rate in intensive care practice, but you will try to augment your cardiac output to ensure that your organ perfusion does not go down. So this actually boils down into what is called as the isopressure curve, a curve that looks at the correlation between your systemic vascular resistance and your cardiac output. Okay, so if you look at the average cardiac output, the intersection of your systemic vascular resistance curve and your cardiac output curve is the point of metabolic homeostasis. So if you try to increase your cardiac output at the cost of systemic vascular resistance, like using inodilators, you will put the patient down into a low cardiac output, high cardiac output, but decrease systemic vascular resistance. So the perfusion actually does not support. So end of the day, the best marker after understanding all this seems to be the perfusion pressure. We have all understood what is perfusion pressure from neurocritical care, and we try to defend the cerebral perfusion pressure in patients with ischemic or traumatic brain with raised intracranial pressure. But the same logic applies to all the perfusions in the body, whether it is coronary perfusion, whether it is intestinal perfusion, whether it is gut perfusion. A combination of mean arterial pressure versus a regional pressure. For example, mean arterial pressure minus central venous pressure or a wedge pressure is the coronary perfusion pressure. Renal diastolic pressure is the renal perfusion pressure. Abdominal, intra-abdominal pressure regulates your abdominal perfusion pressure. So your augmentation, your manipulation of all your pressures should be focused on optimizing your perfusion pressure as far as resuscitation is concerned, and that's where central venous pressure may be coming back into intensive care monitoring tools. The important point we need to remember is that there is something called as a vasoconstrictive reserve and a vasodilatory reserve. Up to a particular point of a diastolic pressure, all your organs are happily perfusing, and that number, based on experimental data in human volunteers as well as in animal models of septic shock, seems to be about 50 millimeters of mercury, and that is the end point of resuscitation. If you can ensure a perfusion pressure of 50 millimeters of mercury, most of your organs seem to be getting the minimum required oxygen supply for their metabolic requirements. And there is a vasoconstrictive reserve which probably seems to disappear when you cross 110 of organ perfusion pressure. So pushing your pressures artificially with use of sympathetic amines may give you a good mean arterial pressure on the monitor, but you are actually vasoconstricting and compromising the organ perfusion pressure. So if you look at the meta-analysis published last week in the NEJM, higher mean arterial pressure targets above 70 in patients with advanced vasodilatory shock secondary to sepsis results in worse outcomes. So between 55 and 70, you may have some scope to play around, especially those patients who are hypertensive in the community. But trying to push your mean arterial pressure beyond 70 or 75 with the use of vasopressors seems to be associated with worse mortality. And this is why vasopressors are not always good. So if you look at vasopressors, they actually give you good organ perfusion pressures in some situations. They may increase your glomerular filtration and they may actually increase the cardiac preload. But what they actually contribute is to constrict the venous capacitance vessels in the periphery and increase the mean systemic filling pressure. The mean systemic filling pressure is the most important driver of your right ventricular end diastolic activity. But on the flip side, they increase the left ventricular afterload, may decrease regional perfusion, and may increase the back pressure of the macrovascular beds. And therefore, they may trigger a hypermetabolic state with cardiac arrhythmia. So there are pros and cons with the use of vasopressors. So early initiation of vasopressors is probably justified on the concept that it is not acting on the basis of increased left ventricular afterload, but by squeezing the capacitance vessels and the unstressed volume back into the circulation and improving the mean systemic filling pressure is where early use of vasopressors is probably helping patients in overcoming the organ hypoperfusion state. Lactate has been the intensivist friend for close to 20 years, and there are a lot of people who apply it, and we also follow the lactate algorithms, and we believe that lactate clearance is an important marker of success of resuscitation. But lactate as a single entity and lactate as a lactate clearance as a marker of successful resuscitation has a lot of caveats. especially in hypoxic patients. If you have patients who have a PaO2 of less than 60 with ARDS in prone ventilation, their lactate is likely to be high even with normal hemodynamics. So that hyperlactatemia should not be interpreted as a hypoperfused state, because as you know, more fluids in ARDS means worse outcomes. So you should understand the context in which the lactate is being generated. Similarly, anaerobic glycolysis, a tissue that is deprived of blood supply because of trauma or because of a thrombotic occlusion, will generate anaerobic glycolysis and produces lactate. So that is a global lactate generation. So you can't interpret that lactate and say, I will give more fluids to clear this lactate. You would be causing more harm to your patients. Similarly, those patients with some of the cytotoxic poisons, one of the experts on poisoning is sitting here. The cytotoxic poisons like aluminum phosphide, for example, they will have mitochondrial dysfunction. There is an uncoupling of the electron transport chain. So they will have lactic acidosis without shock, and those with hepatic dysfunction. So if you remember all these caveats and you understand that this patient is not fitting into these caveats, then probably you are justified in using lactate clearance as the um, marker of resuscitation. What about capillary refill time? Capillary refill time was taught to us as a marker of resuscitation when we were undergrads and postgrads 25, 30 years ago. And we frowned upon it, saying this is witchcraft and this is ancient medicine. And it has come back. Why did it come back? Because one study done in the West said it is good. So all of us have latched on to capillary refill time and said we will. So has it been done in an Indian population, right? And do physicians actually consider capillary refill time to influence outcomes? Lot of physicians in the United States, about 500 of them, feel it is a reliable, reproducible marker, but lesser number feel it has a diagnostic value, but very few number actually feel it is a therapeutic target. You can use capillary refill time to tell you whether your patient is hypoperfused, but restoration of capillary refill time is not enough for you to say that your resuscitation is complete. So that brings us to the AVCO2 gap. This is another age-old concept which we have understood, and this is related to the sluggishness of the circulation. The more time you allow the blood to be in contact with the tissues, the more carbon dioxide diffuses into the blood, and that sluggishness of circulation is a result of a low cardiac output. So if you have somebody whose arteriovenous carbon dioxide gap is more than 6, it means you have to look at points to augment their cardiac output. I may overshoot by a minute, but I promise I will finish as quickly as I can. So if you have somebody whose oxygen delivery is a problem, you have patients who have an SCVO2 of less than 70 and more than 70, you identify the delta PCO2, AVCO2 delta, and see whether it is more than 6 or less than 6. If it is more than 6, you need to have invasive cardiac output monitoring, and you need to manipulate your vasopressors, dilators, and extracorporeal therapy to augment this cardiac output. So to putting it all into the picture, you keep the lactate concentration. If your lactate concentration is more than 2, probably you should look at the SCVO2. And the AVCO2 gap concept comes into the picture in those patients who have a SCVO2 of more than 70. The algorithm for those who have an AVCO2 delta of less than 70 is very clear. For those who have a gap of more than 70, you look at the AVCO2 delta and then see whether they are fluid responsive or not. Different types of shock can be identified by looking at a combination of lactate, anion gap, AVCO2 delta, and SCVO2. You can actually put them into what kind of shock these patients are. So this is something which reflects the same story, starting from lactate through SCVO2 to AVCO2 delta, and you can identify the different types of cardiogenic shock. So ultimately, while you look at the golden triangle, it is now a diamond of lactate, mean arterial pressure, SCVO2, AVCO2 delta, and an optimum CVP that promotes organ perfusion. So at this point of time in metabolic resuscitation of sick patients, we are at this junction where these 5 are going to be your friends during resuscitation. So if you have a patient who has a high SCVO2, probably the system is to go through an AVCO2 delta and see where we are going wrong. So Where are we at this point of time? Probably not where we were 15 minutes ago, but mean arterial pressure appears to be the most applicable marker, which is not rocket science. But perfusion pressure seems to be the incoming thing which is applicable to all vascular beds. SCVO2 may be making a comeback into the ICUs for those, especially those who have a saturation of more than 70%. AVCO2 delta is a promising candidate, and we need to evaluate it more in the context of septic shock. And a combination of markers in the diamond I showed you may be more effective in guiding your resuscitation than using one or two parameters in isolation. Thank you very much. Have a good day. I'm sure there will be a lot of comments. Do we take them now or after?
Thank you, Srinivas. My understanding of resuscitation has totally changed after listening to Srinivas' lecture. If you can take these endpoints, goals into clinical practice, it will be a wonderful.